question, you can type up your question in our chat box. We are going live on Facebook as well, so no worries for those who are unable to join us. You can catch up with the video later on in our Facebook Malaysia Trauma Conference page. So before we begin, two of our esteemed panelists will be joining with us today as well. Dr. Shah Jahan, consultant trauma physician from Hospital Sungai Buloh, and also Professor Dr. Sabaria, consultant emergency physician from Hospital UiTM. So before we begin, I would like to introduce first, our first speaker is Dr. Ahmad Ibrahim. I think most of us know him already. He's a consultant trauma physician from HKL. He did his master's in emergency medicine from UKM. He recently completed a fellowship in trauma care from London. So he will be giving a talk today on proximal humerus intraosseous access. So welcome, Dr. Ibrahim. The screen is yours.
Thank you very much for the kind introduction, Ms. Chairperson. Okay, so I'll share my screen now. Can you see my screen?
Yes, Dr. Ibrahim, we can see your screen.
All right, okay. Assalamualaikum and good evening to everyone. First of all, I would like to thank the organizing committee for this opportunity for me to present on this platform today to share my knowledge with all the audience. So my topic today will be proximal humerus intraosseous access. This is a relatively new topic which many might not be familiar with. Okay, however, in this presentation, I will mainly focus on the benefit of this proximal humerus IO, and also we will focus on the technique of insertion. Okay. Just disclosure, I have no affiliation or investment in any of the company mentioned in this presentation. Okay, I'll start with a brief introduction. This will be a simple and straightforward presentation. So just sit back, relax, and enjoy the presentation. Okay, so what is IO cannulation or intraosseous cannulation? It is a process of placing a specialized hollow bore needle or sturdy needle through the cortex of the bone into the medullary cavity. This is usually done in emergency situation where the IV access fails or difficult to insert, to emergently infuse fluid or blood products or medication into a critically ill patient. So within this medulla, there are vast vascular structure or network which are non-collapsible, means that it remains open even in severely shocked patient. So in severely shocked patient, if you attempt this procedure, most of the time it will be successful and you will be able to give the patient or infuse the patient with fluid or blood products to save their lives. Okay, this is an alternative to the preferred IV route when the latter cannot be established in a timely manner in emergency situation. Means that if you try to attempt IV access and you fail, then this IO access will be alternative. Okay, now we will pose few questions to the audience for you to answer, okay? And then we will look at the poll. So for that, I pass back to the admin, all right? Okay, now you can see the poll. So try to answer all 3 questions. Whoa, whoa, I can see the answer coming in. All right. So everyone, please answer the question. It's not an exam question, it's just simple, straightforward question. Right, we'll give you another 30 seconds to answer. All right, okay. So now we look at the answer. Have you inserted IIO access before? Yes, 35%. No, 65%. So about 1/3 of the audience today have experienced inserting IO access. So we go to the second question. Have you inserted proximal humerus IO access before? Yes, 4%. No, 96%. So I believe most of you have no experience or have no idea what is proximal humerus IO access. All right. So question number 3. Which one do you think is better? So very close. Proximal humerus IO 44%. And 56% thinks proximal tibia IO is better. So majority thinks, or more than half thinks, that proximal tibia IO is better than proximal humerus IO. Are you sure? Okay, you'll get the answer by the end of this presentation. Okay, so I'll share back my screen. All right. Can you see my screen?
Yes, Dr. Ibrahim, go ahead.
All right. Okay. So I'll continue. So a bit of history of IO access. Okay. Drinker et al. Described the bone as non-collapsible vein first in 1922. Okay. And then in 1941, Tocantins introduced the use of IO in pediatrics population. In 1942, IO and IV access time were found to be nearly identical. This is the time of insertion. Okay. And during World War II, a total of 4,000 IO infusions were recorded, and it became a military standard practice. In early 1980s, IO became a standard of care in pediatric advanced life support. In 1994, the world's first automatic IO device were produced. In 2009, first mention of proximal humerus IO in the Journal of Trauma. And in 2015, American Heart Association recommended the use of IO as an alternative when IV access is impossible. Okay, that's a bit of history of IO access. So the photo or diagram that you are seeing now are the different types of IO device. The one that you usually see or you might have used before is A and also D. So A is the manual trocar, which we've been using it for a long time, about 5 to 10 years ago. Nowadays, I don't think many of us still use this. It is cheap, but however, you need ample amount of force to insert it, and the operator must be really trained in doing it. In comparison with D, which we are using, most of us uses now, which is the Easy IO or drill driver based device. It is a bit costly compared to the manual trocar, but the driver is usable. So you only have to buy the needle in order to use this. However, the needle is only for single use. You cannot reuse the needle. Okay, the force needed for insertion is very minimal, and very minimal training is needed in order to be successful to insert an IO using this device. This is how the Easy IO power driver and needle sets looks like. So it comes with the power driver, which is this, and then the package will usually comes with 3 types of needle. The pink needle is 15 mm, usually used in pediatric population. The Easy IO 25 mm or the blue needle is used in patients who are more than 40 kilos and usually used for the insertion of Easy IO at the proximal tibia. Okay. And the longest, which is the yellow needle or Easy IO 45 mm, used in patients who are more than 40 kilo with excessive tissue, and is actually specially designed to be inserted at the proximal humerus. So for proximal humerus IO, one must use a 45 mm needle or the yellow needle, right? So this is the indication for intraosseous placement, which I've actually mentioned earlier. This is done in emergent situation in which vascular access is needed, but peripheral IV access is difficult, failed, or impossible to obtain. There are multiple studies which have shown that IO placement is a quick, safe, and effective way to establish indirect vascular access. Despite multiple or many evidence that show the effectiveness of IO catheters remain underutilized in the adult ED. This might be mainly because of lack of training, lack of confidence, lack of knowledge, or maybe you don't have the device in your department. Okay. How about usage in PHC setting? In Malaysia, I don't think there are paramedics who utilizes IO at the pre-hospital setting. I might be wrong, but actually this is feasible, can be done at the pre-hospital setting. This is just to show you one of the study which showed that paramedics can successfully perform humeral Easy IO intraosseous access in adult out of hospital cardiac arrest patient. In this study, it has shown that the paramedics were successful on first attempt in 91% of cases, and on second attempt in 94% of cases. So what are the fluid and drugs that can be administered through the IO route? So almost all fluids, blood products, and medication that can be administered safely via the peripheral IV can be actually given by IO route. However, it is recommended not to infuse hypertonic saline or vasopressors through the IO route. Okay, so others all can be given. How about blood samples? IO device can be used to aspirate blood samples on initial placement, but only certain tests correlate reliably with IV samples. The tests which correlate reliably with IV samples are HB, hematocrit, glucose, urea, nitrogen, creatinine, chloride, total protein, albumin, and group and safe. Tests which has poor correlation with IV, platelets, white cell count, sodium, potassium, carbon dioxide, and also calcium. How about blood gas? IO sample might damage the majority of blood gas analyzer machines, so it's not recommended. So do not use IO sample on the blood gas machine. It might damage it. So proximal humerus versus proximal tibia. We actually asked this question in our poll earlier. So actually proximal tibia won the poll, but recent literature on the proximal humerus IO insertion site suggests that it is a better resuscitative line than the proximal tibia IO site. So proximal humerus is actually better than proximal tibia due to its closer proximity to the central circulation. It's closer to the heart and higher flow rates. Okay, this is a simple anatomy of the proximal humerus. Okay, so within the epiphysis of the bone, there is a medulla. Okay, within the medulla is rich of vascular network and also sinusoid. So when you insert or put in a IO needle into the medulla, whatever you give will actually get into this space which is rich in vascular supply, and then it will drain out through the canals on the cortex into the systemic circulation through the emissary and nutrient vessels. Okay, these are the canal and these are the nutrient and emissary vessels. It will get into the systemic circulation. This vascular network is non-collapsible, means that it remains open even in severely shocked patient. So this is the advantage of the IO access. A bit more on the anatomy of the proximal humerus. In comparison with the, when we compare it with the anatomy of the proximal tibia, proximal humerus are covered with thick soft tissue. If you can see in this diagram, the lateral part of it is covered by the deltoid muscle. There is also biceps tendon, which overlies the proximal humerus. Other than that, there are also rotator cuff muscles surrounding this area. So our point of interest or the point of entry of our IO needle for proximal humerus will be at the greater tubercle of the humerus, which is around this area, which I'm pointing to now. Because of this thicker soft tissue, we have to use a longer needle. That is why yellow needle is needed in order to reach the medulla within the proximal humerus. So a bit about the IO flow rates. I mentioned earlier the flow rate in the proximal humerus is actually faster and larger volume can be infused to the proximal humerus in comparison with the proximal tibia. So studies in both animals and humans have showed that flow rates in the proximal humerus IO compared higher flow rates in the proximal humerus IO compared to the proximal tibia. And if you use a pressure bag or infusion pump, the flow rates will be even faster. And studies have shown the flow rates actually nearly double when a pressure bag was used. Study also shown that the proximal humerus mean flow rate is about 6 liters per hour in comparison with proximal tibia mean flow rate, which is only about 1 liter per hour. So we can see there's a clear winner here. Okay. So let's watch this video on the flow rate. Okay, I'm going to share the video now. Hope you can see it. Okay, focus on the left of the screen. All right. This is show how fast the fluid reaches the heart or the right atrium when it is infused to the proximal humerus, IO. Okay, I'm gonna replay it again so that you can watch it again. So basically, when you infuse fluid through the proximal humerus, it can reach the right atrium within 3 seconds. All right. I'm going to go back to my slides. Right. Okay. So which needle for proximal humerus IO? Pink, blue, or yellow? So the answer is yellow. So in patients greater than 40 kilo in weight, the Aero Easy IO driver should be loaded with a yellow 45 mm needle, which is specifically designed for the proximal humerus IO. A recent MRI study confirmed that the blue or 25 mm needle length is inadequate for proximal humerus IO and will fail in as many as 50% of adult patients. So use the yellow needle for the proximal humerus IO. So now we go to the technique. There will be few videos that I will be showing on the technique of proximal humerus IO insertion. Okay, before anything, of course, you have to position the arm in the correct manner. There are two ways of positioning it. The first way is to flex the elbow, adduct the arm, and place the patient's palm over the umbilicus. And the second way is to extend the elbow, adduct, and hyperpronate the arm. Don't worry, you can see it more clearly in this video that I'm going to show you. Okay. Hope you can see the video now. Okay, I'm going to play it.
To help better understand the humeral anatomy when we place a humeral IO, in this adult patient, generally 40 kilograms and up, we've reflected back the soft tissue, which you can see will vary from patient to patient. We also have the lateral deltoid. When we marry those two together, you can see how the 45 millimeter needle is essential to go through both layers and through the cortex of the bone. As you can see, this patient is in the supinated palm up position. When the palm is up in the patient, it exposes the bicep brachii tendon. The optimal method is to take the palm and place it over the abdomen. As it does that, it immediately rotates the bicep brachii tendon, leaving a very large area of cortex to penetrate. Again, when we have the palm supinated or up, the tendon is exposed and strikeable. When the palm is placed over the abdomen, it's immediately rotated. If you're unable to place the palm in this position due to patient variances, the alternate method is to take the palm and put the thumb rotated inward and down. It again immediately rotates the bicep brachii tendon, yielding the optimal insertion spot. You can see the surgical neck is where the shaft marries that humeral head, yielding the greater tubercle, which is the ideal location for insertion.
Okay, so that's how you should position the arm. Okay, there are two ways of positioning the arm before you attempt to insert the IO needle. All right. Okay. In order for the IO insertion to be successful, you have before you drill into the needle into the bone or into the cortex, you have to press the needle through the skin until it rests on the cortex of the bone. And when you do this, at least one black line must be visible above the skin. This is to ensure the length of the needle is adequate. Means that if, let's say, look at the left of the screen, if when you press the needle into the skin and soft tissue until it rests on the cortex of the bone, and you can't see any black line above the skin, means that the length of the needle is inadequate and most likely your procedure is gonna fail. Okay, so in order to ensure the procedure will be successful and the length is adequate, make sure at least one black line is visible above the skin. All right. Okay, let's watch another video on the insertion technique of proximal humerus IO. Hope you can see the video now. It's playing.
Place the patient's hand over the abdomen, elbow adducted and the humerus internally rotated. Place your palm on the patient's shoulder anteriorly. The area that feels like a ball under your palm is the general target area. You should be able to feel this ball even on obese patients by pushing deeply. Place the ulnar aspect of one hand vertically over the axilla. Place the ulnar aspect of the opposite hand along the midline of the upper arm laterally. Place your thumbs together over the arm. This identifies the vertical line of the insertion on the proximal humerus. Palpate deeply as you climb up the humerus to the surgical neck. It will feel like a golf ball on a tee. The spot where the ball meets the tee is the surgical neck. The insertion site is on the most prominent aspect of the greater tubercle, 1 to 2 centimeters above the surgical neck. Prepare the site by using antiseptic solution of your choice. Use a clean, no-touch technique, maintaining asepsis. Remove the needle cap. Needle set tip at a 45-degree angle to the anterior plane and posterior medial. Push the needle tip through the skin until the tip rests against the bone. The 5-millimeter mark must be visible above the skin for confirmation of adequate needle length. Drill gently into the humerus 2 centimeters or until the hub reaches the skin in an adult. The hub of the needle set should be perpendicular to the skin. Hold the hub in place and pull the driver straight off. Continue to hold the hub while twisting the stylet off the hub with counterclockwise rotations. The needle should feel firmly seated in the bone, which is the first confirmation of placement. Place the stylet in a sharps container. Place the easy stabilizer dressing over the hub. Attach a primed Easy Connect extension set to the hub, firmly securing by twisting clockwise. Pull the tabs off the Easy Stabilizer dressing to expose the adhesive and apply to the skin. Aspirate for blood or bone marrow, which is the second confirmation of placement. Inability to withdraw or aspirate blood from the catheter hub does not mean the insertion was unsuccessful. Consider attempting to aspirate after the flush. Secure the arm in place across the abdomen.
Okay, so that's how you insert proximal humerus IO. Not that difficult, right? Okay, we'll watch another video now. Okay, this is a video that we actually recorded during our recent Silent Mentor cadaveric workshop.
Okay, and then you're familiar anatomy. Number two, your equipment. Equipment, there is three types of equipment. Number one, the most common, your manual. Okay, later on is a spring-loaded gun. Okay, we advise you use a driver. This is this is EZIO. So for proximal humerus, use the longest one, 45 mm. You have another one is a 15 and 25. Okay? Why you use this 45 mm? Because your genital humerus basically is covered by your deltoid muscle. So you have soft tissue. Okay. So once you're ready, okay, again, get your cervical neck of humerus 1 to 2 cm, your greater tubercle, okay, and then you put it until you reach the bone. So make sure this is very important. This we call it deep gauge. Must at least one black line of 5 mm above your skin. Okay, this means adequacy of your entering the medullary canal. Okay, so this horizontal line, you make about 45 degree, and then aim towards the. It's good you just take medial, or you aim towards your inferior border of your scapula. Okay, and then you drill it and stop. Okay, so you remove your driver, your starlight. So for this EZIO, they have provide to put your starlight. Okay, sharp bin. Okay. Before you put your extension, you put your this stabilizer. Okay. So the first indication where you are in, first you can see there is the hub or your IO needle is stay. Okay? It's not bent or it's not moving. Okay. Number two, you put your connector and then you may aspirate. Okay? If lucky, you may drain some some bone marrow content. Okay. If not, it's okay. And then you need to flush before you flush, because it's documented it's quite painful for those who awake lah. But for example, for trauma patient, cardiac traumatic arrest, patient still unconscious, okay, we advise you to put at least 1 minute of your lidocaine 2%, 2 cc, okay. Once you're in, and then you can flush it. So the third component, how you know it's in, when you flush, okay, there's no stabilization. Okay. Let's say after you put your lidocaine 2%, after 1 minute, and then you flush it. Bear in mind, okay, because this.
Okay, the rest of the stats are fairly similar to the previous video that I've showed you. So how do you confirm the catheter placement? One will be by the ability to aspirate blood or bone or marrow from the tubing. All right, but if you're unable to do it, doesn't mean that your catheter is not in place. Consider reattempting it after you flush it. Okay. Another way is the catheter must be stable, and when you infuse fluid, it must be flowing in smoothly. That's how you confirm the placement of the catheter. So additional step that you might want to consider in an awake patient is to give a small amount of lignocaine, 2%, about 2 mils. Before you flush, you give 2 mils of lignocaine and then leave it for about 2 minutes. And then you flush it off, all right? So IO access can usually be placed within a very short period of time. It is documented as about 30 seconds to 3 minutes. Okay, the landmarks can be easily palpated and successful insertion can occur rapidly, even in patients who are morbidly obese and have severe peripheral edema. One military study showed that proximal humerus IO was shown to have a first pass success rate approaching 96% and second pass success rate approaching 100%. These are some of the contraindications for IO access: unhealed fracture of selected bone, active soft tissue infection at insertion site, previous attempt at the same bone within 48 hours, inability to identify landmarks, prosthetic bone or joint at insertion site, abnormalities of the bone strength, fracture of more proximal bone, inability to immobilize the selected bone after IO catheter placement. One of the most common complications of IO catheter insertion is extravasation of fluid. Okay, and a recent retrospective study have shown a very low rate of complication, only about 1%, 1.38% of cases with complication, and most of it were device insertion failures. Bear in mind that the IO line should be removed within 24 hours after its placement to minimize the risk of infection. What happens if the driver or drill is inoperable or becomes unavailable? You can actually use just the needle to manually insert it in a rotatory movement. Okay, so you can actually press it against the bone and then rotate it counter or anti-clockwise until you feel a give. How about contrast for CT? Can you use IO access to administer contrast for CT scan? The answer is yes, but depends on the institution, practice, or protocol. So in conclusion, proximal humerus IO infusion is an excellent option for critically ill patients in whom vascular access is difficult in ED or even in PHC setting. So now we have incorporated this training of proximal humerus IO insertion in our trauma life support courses. Okay, with proper understanding and indication and also the contraindication for this procedure, reliable vascular access can be established within seconds. And the placement is actually not that difficult, as easy as how you perform a tibial IO insertion. And with a pressure bag, you can actually double the infusion rate and you'll be able to resuscitate patient with a large volume of blood or blood products. Although it is an underutilized tool in the adult ED, it is a valuable technique that can save lives when used properly. So get trained and try to use it when the situation arises. So with that, I end my presentation. Thank you very much.
Thank you, Dr. Ibrahim, for the very insightful talk. Definitely, it's an eye-opener for us, especially in ED, because most of us have been used to doing IO in proximal tibia. So before we proceed with the next speaker, if you have any question, you can always post it in our chat box and we'll answer during our Q&A session later on. So I'd like to introduce our next speaker. Our next speaker will be Dr. Arfa Hanim. She is our anesthesiologist from HKL. She did her master in UPM and currently she's pursuing a subspecialty in neuroanesthesia and trauma. So today, she'll be giving a talk on consideration and approach to central venous cannulation in trauma. So the screen is yours, Dr. Arfa.
Okay, thank you so much for the kind introduction. All right, can you hear me?
Yeah, we can hear you clearly.
I'm going to share my slides now. Okay, all right. Assalamualaikum and good evening, ladies and gentlemen. Thank you to the organizing committee I am utterly grateful to be here today and to be given the opportunity to discuss on considerations and approach for central venous access in trauma. So there are several common central venous accesses, which I'm sure most of us are familiar with. However, today I will enlighten you more on ultrasound-guided axillary vein cannulation, which is extremely useful in effective resuscitation for trauma patients. But before that, we will, go to the poll section to find out regarding our practice in CBL insertion. Okay. All right, so I see that answers are coming in. All right, so this is basically just to see how, the preferred techniques and also the sites that is usually used by everyone. Okay, we'll see how. All right, so clearly we can see mostly using ultrasound guided technique, which is very good and very useful because in our era right now, so this is a gold standard procedure. And then, so the first question, how do you usually perform? I see that almost 80% is using ultrasound guided. And then what is your preferred central venous cannulation? All right, the polls are coming in. All right, mostly prefer the internal jugular vein. And femoral vein comes in quite close as well. Where else? Yeah, there's a few percentage of subclavian vein and also axillary vein. Okay. So the third question, have you inserted axillary vein CVL before? Well, majority of us have never inserted this particular site before. So, all right. So I'm just gonna go back to the presentation. All right, hold on. Okay, can you see my slides again?
Yeah, we can see your slides. Okay.
All right, I'll just continue. So yes, most of us use ultrasound, which is good. And then the most common sites are actually IJV and also femoral vein. So that is common. And today, because most of us have never inserted axillary vein cannulation, I will enlighten you further on this procedure. All right, so although it is not a common access site for CVL cannulation practice in our country, as you can see through the papers, this procedure has been dwelt upon since almost 2 decades ago. All right, mainly discussing on the technique, pros and cons, risk and complication. And most of the studies concur that it's a safe and useful procedure and with minimal risk and complication. And this is one of the preferred technique in terms of vascular access utilized by the trauma physician. All right, so these are the recipe to achieve our aim. So we need a functional ultrasound with linear probe, the desired access site, and also a complete central venous line set. I'll go through each ingredients briefly. Towards the end, I will show you the exciting part, which is the video of the procedure itself. All right, so firstly, with regards to ultrasound, here are the several recommendations. So ultrasound equipment and properly trained operators should be available for central venous access. Prior to the procedure, it is advisable that we will apply ultrasound and see the venous access to ensure that we rule out thrombosis and also ensure that the vein diameter is adequate to prevent venous thrombosis after the insertion. The venipuncture should be performed using dynamic real-time ultrasound guidance, not static, and it is useful for tip navigation and tip location. So ultrasound also can identify the complication that may ensue following the procedure as well. All right. So in terms of the usage of ultrasound, it is imperative that we ensure our posture and also the position of the ultrasound is at a feasible location. All right. The transducer that we use is a linear probe, 5 to 15 megahertz frequency. The modes will be B mode and also Doppler mode. Okay. We need to be familiar with the views, which include short axis, longitudinal, and also oblique. And with regards of in-plane and out-of-plane technique, it varies with one's preference and exact site. I prefer to do in-plane technique for certain site, as out-of-plane technique have higher risk of through and through penetration, risking injury at the other structures around it. But it depends on the site that you are assessing. All right, so in terms of evaluation of vessels, I'm just setting out the obvious right here. So the vein is anechoic. It's oval shaped with thin walls. It's easily compressed with light pressure. There's no pulsations, and also it distends with maneuver. Whereas on the other hand, artery is anechoic, generally circular with thicker walls, and it's less easily compressed. But there are setbacks in which, like, collapsed artery is mistaken as vein in severely hypovolemic and hypotensive patients. So we have to be cautious about that. So it's pulsatile and it remains the same during above mentioned maneuvers. So the inner diameter is advisable to be at least 3 times the external diameter of the catheter to reduce the risk of thrombosis. Because most studies actually shown that the risk of deep vein thrombosis is correlated with the increasing catheter diameter. So there are a few issues that we need to, be cautious about. So it's particularly challenging in morbidly obese patients in view of the thickness of the wall. And then the subcutaneous emphysema, the veins, the vessels are obscured by the artifacts, and also volume depletion, which may increase the difficulty because of the, because of the reducing vein caliber. All right, so now we discuss on the possible access sites and zoom into the infraclavicular axillary vein cannulation later on. So earlier days, I was actually trained to do a lot of subclavian vein cannulation. However, it doesn't come without complication, as it was a blind technique, it is a blind technique, and with plenty of vital structures around it. So generally now in our ICU, we insert internal jugular vein or femoral vein CVL. But I would say that trauma patients with cervical injury and intra-abdominal injuries, pelvic injuries, or those with ICB with high ICP, which you wouldn't want to compromise the venous drainage, as well as the patient with multiple cannulation with thrombosed vein like ESRF patient, axillary vein and subclavian vein seems to be a shinier option. All right, so let's dive into what is axillary vein cannulation and also how is it done. All right, towards the end, I will show you the video of this procedure. So first and foremost, we'll dive into to insert or not to insert the central line at this particular site. As other indications, it is good for fluid resuscitation, particularly because it's closer to the heart as well. And then it's good for patient with poor peripheral venous access, and then CVP monitoring as well as infusion of the vasopressor and inotropic drugs. It's absolutely contraindicated in patient with vascular injury to the ipsilateral subclavian vessels, trauma of the ipsilateral clavicle, as well as the infection or burn at the site of insertion. It is relatively contraindicated in patient who's coagulopathic, who has distorted local anatomy, and also uncooperative patient. All right. So as I mentioned earlier, the types of patient which is suitable for this procedure are those with tracheostomy and polytrauma patients. And the advantage is the anatomy favors ultrasound guidance and it causes less complication. In terms of damage control, the manual compression of the axillary artery or surgical access is possible if arterial damage is caused, and the puncture site is further away from the potential source of infection. On the other hand, it is difficult in patients with who are obese and also with deeper veins. All right, so when we talk about choosing sites, right side is the preferred. I mean, it's preferred due to lower pleural dome, direct route to SVC, as well as absence of thoracic duct. However, under the circumstances of patient with pneumothorax, with existing chest tube, this particular site will be a better option. All right. So now we look at the benefit between doing the ultrasound guided axillary vein puncture as opposed to landmark SCV puncture. Grossly, we can see the ultrasound guided axillary vein puncture has an upper hand in terms of lower risk and also managing the complication. So these two are technical, but it is in ultrasound axillary puncture, it has low risk of arterial, pleural, and nerve damage. It reduces the risk of catheter pinch off. So pinch off syndrome is basically when a long-term central venous catheter is compressed between the clavicle and the first rib. So this happens in a subclavian puncture. It causes a transient obstruction of the catheter and also may result in a tear or even complete transection and embolization of the catheter. So in axillary vein puncture, the risk is much lesser. And as I mentioned earlier, in case of arterial damage, it is a lot easier to actually be managed when you do an axillary vein puncture. All right. So now we go to the third requirement, which is the central venous catheter. So there are plenty of options out there in the market. However, here I'm specifically showing the MAC Aero catheter is because it ticks most of the boxes in Possel's law, in which it will deliver the desired flow rate for effective volume resuscitation because the radius is relatively larger. Excuse me. The radius is relatively larger, and also the shorter length of the catheter allows higher flow as it is inversely related. Okay. So the length of the catheter is about 10 cm, and normally we will anchor at the 10 cm at both sides when we insert. All right. So as you can see, it is. All right, it is highly recommended in trauma patient, intraoperative trauma surgery, as patient is possibly having existing acute traumatic coagulopathy. Also in patient with high risk of bleeding in OT, particularly tumor or vascular surgery, or any circumstances that requires high volume resuscitation. So we have proximal the A lumen, which is the proximal 12T lumen. B is the MAC hemostasis valve, and also C is the distal 9 plus French lumen. So the MAC hemostasis valve is the area where we will mount triple lumen in order to get more access, and it will lead to a 5 access lumen. So patient with peripheral access, poor peripheral access will benefit the fact that we can mount the triple lumen to produce the total of 5 access lumen. So as I mentioned earlier, it's a very good in patient with shock and also trauma. All right. As of all CVL insertion, the complications are the same. There's a complication of infection at the local area, heart colonization with via intraluminal route, the hematogenous seeding from the catheter, as well as there is thrombotic complications as well. In terms of mechanical, it can cause arterial puncture. I mean, part of the complication can be arterial puncture, hematoma, pneumothorax. But in axillary vein ultrasound guided insertion, we can prevent this by using this PART technique, which is a pleural avoidance with rib trajectory technique, in which we will advance the needle directly towards the periosteum of the underlying rib and not towards the visceral parietal pleural interface. So with that, we avoid from causing pneumothorax. So this will be shown later in the video. And then there are risks of malposition as well. And also cardiac arrhythmia, which is may happen during the insertion of the guide wire and also catheter advancement. So we have to be cautious about all this. All right. So post-procedure care, following the procedure, we need to request for chest X-ray to identify the placement and elicit complications, namely pneumothorax and malposition. And the catheter site needs to be properly dressed, and this leads to an important bundle care, which is the CVC bundle care, that should be applied to prevent catheter-related bloodstream infection. All right, so a little bit on the CVC bundle, which is very, very important. So first and foremost, we need to have effective hand hygiene for all procedures relating to CVC. And we need to use 0.5% chlorhexidine mixed with 70% of alcohol as a skin antiseptic. As an alternative, we can use the povidone iodine if a patient is contraindicated or allergic to the chlorhexidine. And then, strict use of barrier and aseptic precautions on insertion. Number 4 will be implement of CVC dressing, change every 7 days and when soiled. The 5th one will be effective use of the aseptic non-touch technique when assessing or manipulating. And the 6th, oftentimes we will forget about this, daily review of line and the necessity. So whenever we don't need it, please do remove it to prevent from infection later on. All right. So we have come to the best part of the presentation, finally a video of the procedure performed by our previous presenter, Dr. Ibrahim, a fantastic trauma physician from HKL during the recent emergency and trauma cadaveric workshop. So the workshop was extremely well structured and executed, in which prior to the axillary vein cannulation skill station, the veins were plumbed up with the fluid resuscitation through the intraosseous access at the greater tubercle of the ipsilateral humerus, which was demonstrated earlier by our presenter. So it was very geniusly planned. So here we go. Enjoy the video. I'll see you after this.
And in this session, we will demonstrate how to insert a MAC arrow double lumen central line into your axillary vein, right? Proximal axillary vein. So this is how a MAC arrow double lumen central line looks like. Okay. Usually, we use this central line to resuscitate hypo. And in this session, we will demonstrate how to resuscitate a hypotensive trauma patient. And ideally, this should be inserted at the axillary vein or the subclavian vein. Now, we'll show you how to identify axillary vein by using ultrasound.
All right. Before that, the hand of the patient should be adapted to assist, to facilitate an easier way to access to the axillary vein site. Okay.
You identify your clavicle, so this is the clavicle, right? So where you put your probe is at this claviculo-deltopectoral groove. Looks like a triangle here, alright? Okay. Right. Okay. This is where you put your probe. Okay. Right. Use the linear vascular probe. Okay. Right. So what you see is at the this is the left side of the screen is the superior aspect. The left side is the superior aspect, and the right side is inferior. Okay. Okay. Before anything, I would like to highlight that the right side is preferable to the left side. Why? Because the right side, the apex of the lung, is lower down, and there is no thoracic duct over the right side. Okay. So the left side too ada thoracic duct, and the apex of the lung is higher up. So the risk of pneumothorax is higher. So what you see lower down is the pleura. Yeah, that's the pleura. Okay. So this I'm putting the probe vertically, or out of plane. So out of plane view, out of plane. So usually we insert this in plane in plane in plane view, in plane view.
Right, so this is the short axis view, and he's going to turn it into a longitudinal view.
So how you do this? You rotate the probe, and this is how the axillary vein looks like in plane view, right? Okay. So of course, in real life patient, you have to differentiate between the artery and the vein. How you differentiate is the artery will be pulsatile, and then it will be the arterial wall is thicker, and you can also use color Doppler to differentiate between artery and the vein. And the vein is usually thinner. The wall is thinner. It's compressible. Okay, it's compressible, and it varies. The size varies with respiration. Okay. Okay. So now we try to.
Okay, he got the longitudinal view. See the fluid streaming inside the veins. Can see the needle trajectory was heading towards the periosteum of the underlying ribs. Okay.
Okay. See? Now we here. Insert the guide wire. We remove the Okay, we remove the needle. And then we insert the double lumen Mac arrow with the dilator preloaded. Preloaded. So we come up through the hemostatic valve. And then you have to make this, bear in mind this is a very large catheter, so you have to make a big incision. Then you insert. If you can't really, say you rotate while inserting in circular motion. Okay, and then you take out the guide wire and the dilator together. Right? So now we try to explain. Okay, successful cannulation. Alright. So when you infuse blood, you should infuse blood through the for resuscitation purpose. What you use is the brown pot, brown colored pot. It is the largest. It is the largest, which is 12 French size. Okay. You can infuse up to 30 liters per hour, theoretically lah. But in real life, I don't think you infuse that much of blood. Alright. Okay, and then there are also other steps. But I think for this demo purpose, we stop here. And then you can.
So, okay, so this was the previous intraosseous site, which we infused fluids to plump up the vein. And as you can see just now, Dr. Ibrahim has successfully inserted the CBL through the axillary vein. So in conclusion, I mean, like it is definitely a new avenue for all of us to try. After this, of course, ultrasound guided, and we need to pick our battles, make sure that the patients that we choose is the right patient and does not have contraindications in doing this procedure. So, all right. So with that, I thank you.
There's also another.
All right. Have a great weekend and Happy New Year to everyone. Thank you.
Thank you, Dr. Arfa, for a very great presentation. It's definitely an eye-opener for us, especially axillary vein access. There's one question I hope Dr. Ibrahim can join us. There's one question I think is for both of our speakers. Dr. Ibrahim?
I'm here. Yeah.
Oh, yeah. So there's one question from the chat box. They mentioned that asked that can we use both humerus IO and axillary vein at the same site?
The answer is yes and no. Yes, you can insert, but once you get the axillary vein, you manage to cannulate the axillary vein, ideally you should remove the proximal humerus IO, because the longer you keep, the higher the risk of infection. So once you get to insert, or you manage to get an IV access, then you should remove the IO line as soon as possible.
Okay, thank you, Dr. Ibrahim. Another question actually for Dr. Ibrahim. Okay, for someone who's very new to insert IO in the proximal humerus, do you have any tips in how we can actually minimize the error during incision?
Actually, the proximal humerus IO is easier to insert compared to the proximal tibia, and the success rate is higher. So if you ask me whether there's any tips, I have no specific tips, but you should get trained in the technique of insertion. So currently we provide the training in our trauma life support course in Hospital Kuala Lumpur and Hospital Sungai Buloh. So you may want to join our courses in order to be able or to get trained in forming this fairly new technique of IO insertion.
All right, thank you, Dr. Ibrahim. Can you please switch on your video? Okay. All right. There's another question as well. Can we actually use level 1 through IO?
Answer is yes.
Okay. All right. And then for Dr. Arfa, yes, for someone who actually hardly put in an axillary vein central line, do you have any tips for us? Any extra tips?
I'll be honest with you, this is something new for me as well. But tips in terms of whatever Dr. Ibrahim have presented before. So basically, of course, with all the other CVL insertion, you have to know your indication and also contraindication. In terms of axillary vein cannulation, at the beginning will be the position. In terms of tips, what do you mean? Like
increasing
how
the
to
success
insert
rate.
or, sorry?
Increasing the success rate.
Increasing the success rate. Of course, using the ultrasound itself is a gold standard. You need to identify the vessel, of course, because sometimes when you ultrasound, you identify the vein, and you have to make sure that it's something that is, I mean, the vein caliber is enough, is adequate or not. There are people who have smaller veins and all that, so you have to assess all those beforehand itself. And then the thickness, I mean, as I told you before, there are patients that might be challenging, those who are obese, those with subcutaneous emphysema, and also hypovolemic patients and all that. So these are challenges that can happen. So we have to address that prior to the insertion itself. So ultrasound, making sure that your access is good. I mean, it's accessible, is a very good technique prior to doing it. Yeah.
Thank you, Dr. Arfa. So another question for Dr. Ibrahim in the chat box. In regards with IOSS, once we got IOSS, should we start any prophylactic antibiotics?
I haven't come across any literature that recommends to start antibiotic prophylactically for IO insertion. And this procedure or this access shouldn't be kept more than 24 hours to lessen the risk of infection. So the answer for that is, I think, no, but I haven't come across any literature that actually mentions about this.
Okay, thank you, Dr. Ibrahim. Another question also for Dr. Arfa. How about a patient who has lots of body hair? Is it advisable to shave that area? Or should we get another central IVSS?
I mean, you can definitely shave the area. There's no harm in that. It's not like a absolute or relative contraindication. Definitely, you can shave the area, and also provided there's no fractures, there's no injury at the subclavian on the ipsilateral side, you can proceed with insertion of axillary vein. Yeah.
All right. Thank you, Dr. Arfa. I think there's another question, I think, for both our speaker. How to get credential doing this procedure, both IO and also axillary vein access?
Dr. Ibrahim.
Credentiality.
Credential them.
I think if you are working in emergency department, then you usually credential by your superior. Means your specialist who supervise you. So you don't need a special credentialing for this procedure, because it's a routine procedure which is done or performed in emergency department day in and day out.
On our side as well, same thing, but of course, it is utmost important that the person is familiar with the procedure, is trained, and probably under supervision, then we can proceed with the procedure because it does comes with complications. So we have to make sure that the person is either trained or with someone who's very trained to supervise them. Yeah.
Okay. Thank you. I think this is the last question for Dr. Ibrahim. Is there any risk of osteomyelitis with IOSS?
Yes, there is a very small risk of getting osteomyelitis due to this procedure. Actually, I have stated in my presentation, but I didn't highlight it because the risk is very low.
Okay. I think that's all for now. That's all the questions in our chat box as well. So thank you again, Dr. Ibrahim and Dr. Arfa, for joining
Thank
us
you so
for the
much.
great talk.
Thank you very much. Hope
Thank
you
you for
enjoyed
having
the
us.
presentation.
Okay. So for all
Happy
the
New Year,
parties,
everyone.
Yeah, Happy New Year.
all right. So for all the participants, we'll be providing a QR code at the end of our session. Do scan. Once you have scanned, fill up our Google form and we will provide certificate. Do bear with us. Certificate will be provided and emailed to you within 1 to 2 weeks. Okay. So hope to see you all next year. Happy New Year and have fun. Take care.
Thank